to start recording if that's okay with everybody.
Okay.
Morning all.
There we go.
Morning or afternoon.
Right. Have you started recording then, Joe?
Yeah, that's recording now.
Okay, so we're all recording. This is going to be put up as a YouTube afterwards on the Faculty of Clinical Informatics YouTube site, which you can all subscribe to. There's already a couple of things up there, and we hope to be augmenting that in the future with a series of seminars. This is the second seminar in the series, really. Okay, so if you've all taken note of the housekeeping slide, I'll go on to the next slide. So this seminar is about clarifying how COVID and coronavirus are being coded and catered for in SNOMED CT, and it's an evolving situation since the beginning of the year, which has got the potential of causing a little bit of confusion because a lot of the concepts, which remain the same, have got different descriptions and preferred terms. And because all of the different systems in the different instances in the 4 countries, the GP systems are in different phases of evolution of SNOMEDization, then they have different core coding issues. But we've tried to simplify this by encouraging all of the system suppliers to use the same term descriptions, and that will be described in much greater detail by our group of experts. So we wanted to standardize the term descriptions used in all systems wherever possible. And of course, external analytics of the codes will be possible because the concepts which are used are either directly mappable to or directly transferable from all of the systems. At least we hope that will be the situation very soon. We've tried to give advice on which concepts to prioritize about 7 concepts to describe various issues around coronavirus and COVID. It is evolving work, and so the latest version you can find on that link. So it's the Faculty of Clinical Informatics main website and coding advice. It's also available from the ribbon bar at the top of the homepage. So next slide, please. So we've got Dr. John Williams, who's the chair of faculty, opening up for this, and then Ian Thompson from Scotland, Julian Costello from Wales, Michael McKenna from Northern Ireland, if he can make it. I'm not sure if he's on the call at the moment, and Jeremy Rogers, coding specialist from the NHS. And then we'll have questions. So those people will form the panel. So over to you, John.
Nick, you skipped a slide. Do you want to just quickly go over the agenda? Go back a slide and go over the agenda.
Sorry, okay, yes, I did. So introduction to the coding list from John, 10 minutes. The national perspectives from Ian, Julian and Michael, 5 minutes each. And then we hope to leave about 25 minutes for questions and answers, and then closing remarks from me. So I'll try and chair and field the questions. If you want to write the questions in the comments panel on the right, you have to reveal that using the floating toolbar. And now I can continue by handing over to John.
Thank you, Nick. So, yes, I'm chair of the Faculty of Clinical Informatics, retired GP, was a GP for 30 years, have had quite a lot of experience in coding at the coalface, and have had an interest in GP data stretching back to the late 1980s. Can we have the next slide, please? So I thought I would just quickly outline the problem. This is an unprecedented problem that nobody living has really ever seen before, as far as I can tell. We've gone from a situation where a mysterious severe pneumonia appeared in Wuhan, China, late last year. And that's evolved very rapidly to the point where we are now with a pandemic and with lockdowns and heaven knows what going on. So effectively, it's a previously unknown disease caused by a never previously seen strain of coronavirus. So of course, neither the disease nor the virus had any name. And so that caused serious problems from the outset. And we had no means to codify in our electronic patient records. So that was the big problem we had, a rapidly progressing serious problem worldwide, and no easy way to be able to name it and to record it. Can we go on, please, Joe? Thank you. So it's very easy. It would probably be very easy in the future for people to look back and say, well, why on earth did people do that? But actually, I think what I'm going to do is display this as how the system actually adapted remarkably quickly, and everybody did their best to try and help to solve the situation. Anyway, we had name changes occurring in rapid succession. So over February and March 2020, first of all, we had to start off with the suppliers deciding to name the virus 2019-nCoV Wuhan. Then shortly after that, people agreed that Wuhan was a bad name, and we changed the name to 2019-nCoV, novel coronavirus. And then latterly, we've had an authoritative international statement that the name should be SARS-CoV-2 Severe Acute Respiratory Syndrome Coronavirus 2. Sadly, as you can see, the name of the virus is getting longer and longer and longer, which is a problem, but that's the official name. The disease, on the other hand, has gone from being called a 2019-nCoV Wuhan infection to using the novel coronavirus version, and then finally, mercifully, a nice short COVID-19. So we now have a very clear disorder called COVID-19. Can we have the next slide, please? So as I said, rapid adaptations took place. GP system suppliers, never heard this happening before. Within days, they all agreed to deploy the same 5 system-wide local codes with exactly the same codes, following that Wuhan naming convention. And at pretty much the same time, unprecedented, NHS Digital UK Terminology also was working very hard on this to produce an emergency release, which followed shortly after that. And they were able to take account of the fact that Wuhan was a bad name, so they used the name novel coronavirus. Well, that's great, except of course it meant that the first naming convention was now out of sync with the new one. We also had a problem that the GP system suppliers hadn't actually quite geared up at that stage to deploy it. So we had a lot of confusion as to what concepts were out there and what on earth people could use to record what. And then finally, later in April, there was a second emergency release by NHS Digital, and that used the latest naming conventions, the SARS-CoV-2 naming convention for the virus, COVID-19 for the disease. And because SNOMED is adaptable, they went back and looked at the preferred terms of all of their original March concepts and changed their names from novel coronavirus to SARS-CoV-2 and made various other changes. So all of that perfectly proper from a terminological point of view, but it didn't half cause chaos for people trying to give advice to GPs as to what on earth how on earth to record things and which particular term they could find on their systems. But I would stress all of this is people working really hard and very fast to do things at unprecedented speed. Next slide, please. So following all of that, various people have tried to coordinate this and to kind of clear up the confusion and help to get some order into things. So following that April release, PRSB, Professional Record Standards Body, worked with NHS Digital, and they have issued comprehensive guidance covering what are now some 70 plus COVID-19 related concepts. And that advice is available up online. What we did in the faculty then was to use that advice as a base, and we decided that what we wanted to do is to try to come up with a list of concepts, essential concepts, that we thought most GPs would want to have to hand whenever they were dealing with somebody with suspected COVID or definite COVID. Not a comprehensive list, but just something they could have by them that would tell them, okay, I've got a suspected case. How on earth do I record that? Or want to record the fact I'm getting them to do a swab on themselves. What do I use for that? It was that kind of advice. And we also took advantage of the fact that we thought this was a great opportunity to try and get the same descriptions to work across all 4 countries. So so 2 things: ending the confusion and trying to get some agreement across the entire UK as to what that set of descriptions should be. We decided it should be based on the April SNOMED CT release. And also, I think the PRSB and our actions have probably stimulated the GP system suppliers to sort out deployment. So they've quite rapidly gone ahead and deployed that latest release. That's certainly true for TPP System 1 for EMIS in England. I think it's also now true for Vision. They certainly started that deployment last week. I'm not sure if it's complete yet, but I suspect it probably is. And we now have got measures in train to ensure that the same set of 19 descriptions will become available across all 4 countries. Can you go to the next slide, please, Joe? Thank you. So what are we trying to do? Well, what we're trying to do is first and foremost to provide clear guidance about which descriptions should be used to capture essential information related to COVID-19. That's obviously important for both individual patient care and, of course, for population statistics, because GP data looks like it's going to be a really important source of stats that will help us to sort out how best to get out of this crisis. We also want, and along the way, we want therefore to promote best recording practice for best data quality. And finally, I think the prime mover here, to remove the confusion that still exists around naming. We go to the next slide, please. So what have we got in that starter list? Well, essentially, we've got the ability to capture the fact that people have been exposed to COVID. We've got an epidemiological case classification, which I'll go into in a moment. Swabbing, we've got some things about laboratory test confirmation, coding for telephone consultation and advice, and coding for self-isolation, signposting to online note service, and also the coding for high-risk stratification and shielding. And we thought that that would be a pretty good starting list. We go to the next slide. So a bit more about the epidemiological case classification. And obviously different organizations may classify individuals differently, but I think there's pretty strong international consensus actually. So a suspected case would be somebody who's been exposed, for example, who's been exposed to the condition and has the classic sort of symptoms of high fever, sore throat, breathlessness, those sorts of things, but hasn't had a test that confirms the condition. A probable case, that's a little bit more difficult, because that would be a case that's been diagnosed on clinical grounds or possibly on MRI or scanning grounds, something like a ground glass appearance on a scan in the lungs, for example. So that's a probable case. A confirmed case, I think pretty much everybody agrees that to be a confirmed case, there must have been a laboratory test confirmation. And right now, there's only one test available, and that's essentially the polymerase chain reaction test for RNA that looks actually for the virus. So they have to have a positive test for that to be a confirmed case. And not a case, we've got things that say COVID-19 excluded or excluded by lab test. And a lot of us are a bit uncomfortable about that. But from an epidemiological point of view, what that actually is saying is that right now, as of this time, this person is not a case, which is perhaps a slightly more accurate way of describing it, because of course next week they might well have a positive case and then become a definite case, a confirmed case. And likewise, we've got excluded by laboratory test there, and that's basically how the not a case becomes not a case, that it's that they haven't so far had a positive test. Can I go to the next slide? So then we thought it might be helpful to just give a little bit of a rationale for the content here and why we did it. So Joe's going to now just quickly load up the English guidance sheet. I'll just quickly run through that, if I may. So it's got a little bit of wording at the front just to explain what it's about. Can we just wind down a little bit, Joe, to the bit that talks about the Wuhan? So then there's this box here that talks about the original 5 terms that the suppliers provided in England, which talk about Wuhan infection. And we're saying to people, don't use those anymore. Instead, look for the descriptions on the right and use those instead. So that's nicely clear, I hope clearly laid out. In the next paragraph, we deal with the slightly sticky problem of what we do with this old testifier 2019 NCOV. I'll not go into the detail of that now, but you can take a look at that and see what we've said about that. Then winding down as we have now, you can, oh, sorry, I didn't mean to do that, Joe. That's it. You can see we've also said, please don't use the older, less specific coronavirus terms, because we know, for example, from RCGP-RSC, that people have used those old terms quite a lot. The rate of usage has gone up quite significantly as the number of cases of COVID has gone up. Can we just roll down a bit more, Joe? Okay, so we thought that if the GP is faced with a patient with COVID, they might well want to record the fact that this is a telephone consultation. So we've got that. Likely the patient has been exposed to COVID-19, so that's there. Then you've got the idea of a suspected case and what to record for that. If somebody is a suspected case, presumably it's likely that somehow a swab will be organized, either to be taken by a healthcare professional or perhaps now increasingly likely taken by the patient. So those codes are there. We wind down a bit, Joe. Then we've got a couple of things that deal with positive and negative results for the PCR test. Either the SARS-CoV is detected or it's not detected. So we've got codes to deal with that. We've also got the disease-related codes, disease COVID-19 confirmed, COVID-19 excluded by laboratory test, if people prefer to use those. Then we've got this idea of a probable case, and you can see we've put there, use that with care, indicates a judgment that the disease has been confirmed by a clinical picture, other investigations such as imaging. We need to be really careful about that one, not to treat that as a definite case. And then we've got the definite case, COVID-19, and underneath, below that, we've got not a case. And then on the next page, this all fits on one side of A4. On the next side of A4, we've got a few things that we thought would be helpful. So they can record the fact that they've given telephone advice, the fact that they've signposted people to NHS Online Isolation Note Service. The high risk stratification code is there, which is clearly at the moment thought to be a pretty important thing. Coding about self-isolation and coding about shielding. And that's about it. That's broadly what the advice is about. So Joe, can we go back to the slide pack again, please? So I hope that gives a bit of an overview as to what's in the guidance and why it's there. So coming back to next slide, that's it. I thought I'd just very quickly say what's not covered in this and what's deliberately not covered. We're not covering pathology tests at the moment. There's a stream of work that's going on elsewhere and which will result in a further emergency release of SNOMED CT, and that's expected to cover tests for virus detection and antibody detection, IgM and IgG, possibly IgA as well. Works in progress also to overcome the problems with PMIP and EDIFACT messaging. In England, we cannot actually add any new tests to be transmitted by the traditional method by PMIP EDIFACT, because we can't add read codes and we can't add things to the pathology bounded code list. So we have a cunning plan to be able to use the EDIFACT message in what's called non-coded mode. I won't go into the detail, but we're getting growing confidence that we will actually be able to get these results to flow from labs into general practice. More about that later on our website when we have the detail. Next slide, please. So then I'm just going to try and use this as a bit of a bridge to our Scottish, Welsh and Northern Irish colleagues. When we migrated our GP systems to SNOMED CT in England, we had to insist for all sorts of reasons that they would dual code, that they would actually code every entry, historical and prospective, using SNOMED CT and also whatever was their coding system, READ2 or CTV3. And that dual coding means that now that new SNOMED CT content is being added, those same suppliers need to maintain that dual coding. They clearly can't use a CTV3 code or a READ code, so they have to create their own system-wide national codes, EMIS national codes, TPP-Y codes, Vision pseudo-read codes. So they are all in existence and all sitting there in those systems. That's actually a very lucky consequence for perhaps for our colleagues in the other nations, because it means that they have ready-made a list of all of the national codes, the system-wide national codes that they need in order to be able to adopt the same descriptions. So at that point, I'm now going to hand over, if I may, I think it's to Ian, and let him take on the baton for Scotland and his colleagues in the other countries.
Thank you, John. If we can move to the next slide, please, Joe. So that's slightly cropped off there, but basically what we've tried to do in this slide is to pull together the descriptions and then the various codes that exist in both EMIS and Vision, which are the two relevant ones for Scotland, with the local codes that John was mentioning for TPP that is in existence in England. That's basically a summary, I think, of all 19, though it's possibly cropped slightly for the screen there. But the idea being that the term description is common across all systems. And so at a point where we in Scotland eventually move over to SNOMED CT, the migration path is a lot easier because we've got lexically identical terms. If you move on to the next slide, please. So this is just a list of systems that we know are in use in different areas. In Scotland, we've got Vision and we've got EMIS PCS. We're expecting these terms that we saw on the previous slide to appear probably the end of next week, though we're still waiting on exact clarity from our suppliers. Similarly, in Wales, there's EMIS Web and Vision, and in Northern Ireland, EMIS Web Vision, and they have another supplier called Murloc. I can't see Michael McKenna from Northern Ireland joining us at the moment in the list of participants, but I'm going to hand on now to Julian from Wales to see if he wants to add a little bit about how things are going in Wales.
Thanks, Ian. Yes, in Wales, as the slide says, we're almost a 50-50 split with EMIS Web and Vision. Both suppliers for us are implementing the full code set, but obviously we're concentrating on releasing the guidance around the 19 selected codes that and those won't be implemented for both our systems until next week. So you'll see on the faculty web page that I haven't uploaded anything for Wales because I thought it'd be more prudent to wait until the concepts or codes are available to us in Wales. We are still dual coding, same as Scotland and Northern Ireland. We're not, or the systems are dual coding. We only have access to the read code and pseudo read codes. Interesting. Of the codes that aren't of the 80 odd codes that aren't being recommended, things like COVID vaccination given or offered. We've done a quick search, I understand, on our systems around Wales, and at least one practice in Wales has already apparently given a vaccination. I think probably the free text would say not, but who knows? So that's a good, illustration of why I think we all want to work along with these 19 concepts. As we said, I don't think Mike's on. Is he from Northern Ireland? But I think they're very similar as to the other Celtic nations. Their Murloc system is, I believe, is CTV3, not the same same as TPP, who've been using their sort of Y codes, but I believe that they have a similar system for a local CTV3. Okay, thank you. Are we back to John, or is it back to
Nick, I think.
To Nick, yeah. Okay, thank you.
So, back to me means question time, I think. Is that right, John?
That's what my agenda says, yes.
Yep, good. Okay, well, I've been looking for questions. Jeff Schrecker has the first question. So, Jeff, if you could expose yourself to the camera and unmute your microphone and ask the first question.
You didn't tell me I'd have to do that. I might not have asked a question. Yeah, I just a little concerned because the description of the high risk code, which we all know is for people who are in that high risk of complications and basically high risk of death from COVID. But reading the description, somebody just using a code browser in a system, it looks like a code that is for somebody who's at high risk of contracting the disease. So I can see that code being inappropriately used when somebody sees a patient who's been to a ski resort where there's been lots of COVID, or has been to a rave where there's been lots of COVID. So that just slightly concerned me that that description doesn't actually describe what we're saying it's to be used for.
Shall I comment on that, Nick?
Yes, please, John.
I don't think you're alone in having that concern, Jeff. But I'm going to actually put Jeremy in the hot seat on this because
yeah, which description are you talking about?
There are actually two kinds of risk that need to be assessed here. And Jeremy, can I get you to explain what those two differences are, and maybe also put up a defence for this?
Well,
please?
so the first question, can you hear me?
Yes,
Yeah.
we can.
Yeah. So the first question, I guess, to Jeff is which description are we talking about? Which particular piece of text?
The one that popped up on the PDF that John showed us.
If somebody could, the reason I'm asking is because the preferred term for the SNOMED code, as stated by SNOMED, is high risk category for developing complication from COVID-19 infection.
Ah.
Which I would say is, we work very hard to distinguish it from the alternative of high risk of catching. So very similar to the notion of close contact, highly likely to have caught it because of that kind of thing. So the official description with the official code, I would like to believe is pretty clearly that it's the high risk of bad stuff happening if you get COVID, not the high risk of you getting COVID. In which case the issue may be with, the trouble is it's a long-winded phrase, and as with all things terminological, if you try to be very precise and exact, you often end up with very, very long and unwieldy phrases that nobody likes, and then they sort of simplify them, and then we go around in circles. What's Joe's frantically trying to find the right bit of text.
Sorry, I was asking 17. Was it on this slide?
It was on the PDF that we scrolled down through.
While Joe's clicking around, there may be another explanation which is worth serving up, which is that when NHS Digital and the powers that be decided that they had to act urgently to populate GP records from the centre with a code saying this patient is in the high risk category, they wished to
Scroll
move
down again.
before we had released the official codes and the official descriptions, and certainly before the nowadays official codes had been widely deployed. So in order to make that entry into GP records, they demanded an existing code that was in SNOMED and was already known to be deployed across the entire estate. And therefore that by its nature predates the discovery of COVID as a disease even, that they could co-opt and misuse for this very specific purpose.
Down a bit, Joe.
So I was given the task of digging about in SNOMED for something sort of.
Yeah.
So we've got to record.
I think the problem there is that the faculty guidelines probably needs the first column updated to match the SNOMED description.
Right,
so,
because
Jeff.
What concerned me was that if that's what's appearing in the clinical system SNOMED CT browsers, that will cause confusion.
No, so what would appear in the clinical system is the middle column.
So
good.
Jeff, I think you're making a good point. Can I now we've got this in front of us, can I just point out a couple of things? First of all, the left-hand column, we've tried very hard to stick to what the PRSB has had to say. So they talk about COVID-19 risk stratification, and in that case, high risk. But that's not what will appear in the system. What appears in the system, as Jeremy says, is what's in the middle column. And that's, I think, pretty clear as to what it means. It may mean that what we should do is we should modify the left-hand column to make it much clearer as to what this is about. So thank you for that comment.
Okay. Can I intervene as chair of the webinar and ask for another question now from Tom Nichols?
Hello, everyone. So the screenshot you've got up is quite useful for the point I want to make. We are used to communicating read codes and knowing read codes, and if I say capital H33, many of you will immediately know exactly what I mean. Then the code, the SNOMED concept IDs are not human readable. If you can see the cell that you've got in your table, it's become truncated and the last few digits have moved on to the row beneath. I've already started to see.
No, they're separate
codes.
Yeah, they're TPP,
the Y codes are
local
TPP
Y
codes.
codes.
Okay, fine. Let's assume that I was right, because you will have tables.
But you're not
in which things
supposed to
get
remember the
truncated.
SNOMED codes. That's the key point here.
You're not. But there's also another danger that I want to point out here. Where you have got those numbers, you're suggesting that people have to transcribe that from a document like a PDF, and that's risky. They either have it on a piece of paper or another document on another screen, whatever, and they type in 124071, or they attempt to select that and copy it and paste it. It's not a safe way of communicating precisely what you want them to find. So this was discussed at a variety of different conferences, and I think it was one of Jeff Schrecker's points that a safer way of being precise is to use the fully specified name. If you do that and you've got the observable entity in brackets or the finding or whatever it might be, then firstly, it is as precise as the concept ID in the first place. Secondly, it's human readable. And thirdly, if you have a copy and paste error or a manual transcription error when you're putting it into a term browser in order to construct a resource such as a search or a data entry template, you're not going to make a mistake. So my recommendation to you would be that rather than putting the concept IDs in, that you put the fully specified name in, or have both if you really must.
John, would you like to answer that?
Thank you, Nick. Tom, you're making a very good point. I don't think any of us here would disagree. Maybe again, we need to make clearer. In the preamble, we've said very clearly that we expect people to look for the descriptions. And there's also in the preamble the statement that the coding is present for those who need to know what the codes are. So it may be that we simply need to make it clear that there's no expectation that anybody would be using those SNOMED CT concept IDs to be finding stuff. I'm actually trying to think whether it's possible on systems to do that. Is it possible to actually attempt to put in a SNOMED CT ID and get back the description? Anyway, we would agree entirely with your points, but there are other users of this list than people who are going to be entering data into the record. And it, for example, acts as a very useful check if we want to get NHS Digital, for example, to run a score over our sheet to make sure that we haven't got anything wrong. So entirely agree with you. We need to make it clear that we would discourage people strongly from using SNOMED CT codes to enter data. Actually, the Y codes are only there because there was a problem earlier on with TPP that it was not possible initially for users to search on the SNOMED CT descriptions. So temporarily, we put the Y codes in there. I'd like to take those out. And when I'm confident that TPP users can actually search on the descriptions, I think that's what we would do.
Can I, in my Haperworth?
Please.
So in a SNOMED world particularly, in the context of data entry, I don't believe anybody should ever see, and certainly should never type, or copy and paste a SNOMED identifier. And from the point of view of trying to propose these codes and standardize their use, it's not brilliantly likely to be successful if you just ask people to look for the descriptions and when something appears on screen to match what appears on screen with the middle column of the table. A more effective method is a variety of structured data entry forms where this coding is kind of hidden in the background. And you may be able to have slightly shorter bits of text appearing on screen to make it fit. And I don't remember whether John has any examples of those. We know they exist in a few of the systems, and where they don't exist, I would encourage people to go down that path rather than this rather more piecemeal matching thing. I guess we've got used, because the codes in READ and V3 are relatively short, people have got used to being given guidance like this, where a quick way to verify that you've got the code intended is to compare the code strings visually on screen. But I still don't think those were ever intended, that you would type the code strings in. Excuse me. But the other scenario where you kind of do need the code strings is from a retrieval point of view, to say, well, what should I be looking for retrieval? Especially if, in fact, the same clinical idea, so for example, the fact of being a COVID positive patient, can be referenced and recorded in more than one identifier across the estate, which is where we currently are. So it's always a bit difficult to sort of frame one document and keep completely separate the data capture concerns, which in an ideal world would not mention the codes, and the data retrieval or code equivalence information which you need for retrieval stuff. And so especially when it's all put together in a hurry, they do tend to bleed together. And I think that's perhaps what we're looking at a little bit here.
Thanks very much, Jeremy. I wonder if I can move on now. There's another question from, this time, Ian Arrowsmith. Hello, Ian. Can I ask you to put your question?
Yeah, sure. I'll just say it's a very interesting and informative session. Thank you for letting me join. Couple of related questions, really. The first one, really, do we have any usage statistics for those earlier Wuhan codes released this year?
John, do you know anything about that from your work in Oxford?
Yes, they were used, and we did find them. I think that we're not finding them now because the suppliers have largely removed them. They're not available on picking lists, but yes, they were used in the early stages. However, we also found an awful lot of non-specific coronavirus codes being used. I don't know whether you're on the call, Ian, but at the top of this list, there's a set of.
Oh, I did see those. Yes.
Yep.
Yeah, the really old ones.
Yes. So we found that the usage stats of those significantly peaked earlier in the year. We know what the background use of those was, and we could see that they had very significantly peaked. So we had to actually assume in the early stages that when those codes were being used, people probably actually meant COVID-19. So we had a mixture of the Wuhan codes, the non-specific codes at the start. It was a real muddle.
Sort of a follow-up question on the same topic, really. So have the GP system suppliers been advised to replace those earlier essentially temporary codes?
Yes, and I believe they have. So if you look on TPP System 1,
yeah.
I think the only one you can find is the tested 2019 NCOV. I think that might still be there.
I wasn't meaning for prospective data entry. I mean for the things that they actually entered then. Did they retained their original entry, or have they been?
Oh, they I think will remain in the record as they were entered, but
okay.
they're not. Sorry, let me just be very clear. They won't. I don't believe they will have changed the entries in the record, but they will have removed them from the picking list. What EMIS did is to edit the Wuhan word out, and they replaced it with novel coronavirus. And I think that, Jeremy, you will confirm that in many cases that's actually now a synonym of the preferred term. So that was quite a smart way of bridging the gap. But it added to confusion because we then had a situation where we had the Wuhan term, the novel coronavirus term, and the SARS-CoV-2 all circulating at the same time. So the aim of this exercise is to say, forget everything and just go for SARS-CoV-2 and for COVID-19 for the disease.
Great, thank you very much.
Thank you, Ian. There's another question from, this time, Janice Watson, who's got an interesting question about inconclusive tests.
Hi there. It was just amongst the list of the local codes. I noticed there were things for positive and negative, but I just happened to notice that it didn't have anything in it for inconclusive tests or a technical failure, because I know that can happen with some of the other sort of things that come up from doing local codes before. So is there a need for that? And if there is, are you going to include one?
Says Jeremy here, there is a need, and they were released yesterday as part of the third emergency release. One of the other aspects of the question of how do we get results back to GPs in a world where at the moment the only way of testing is some form of real-time PCR testing, but we expect other modalities of testing to come on stream as soon as possible. You know, the magic pregnancy test style stick is the one everybody's waiting for mass testing. And so when you ask for a test to be performed from general practice, at the moment, the only test you can practically request is a PCR test. But generally speaking, what you really want to ask is, tell me whether they've got the organism or not. And I'm not going to tell you how to test for it. And the result you want to get back is, yes, they have, no, they haven't, I'm not sure, or I lost a specimen, or something went wrong. And so there are 4 result codes that capture those 4 senses against the idea of testing by whatever means the lab chooses to use for the presence of the organism, so an organism detection test. In the same way as we move to antibody testing, when that becomes available at a wide scale to test for people who have been infected and may or may not be immune, there is another quartet of codes similarly to report whether or not the patient has IgG, and another quartet for IgM as of yesterday. But of course, those are only now winging their way towards the primary care suppliers and also to the laboratories, because as John alluded to earlier, the process of getting this all the way back from the labs where this testing currently takes place is somewhat hacky, to say the least. So that will come on stream, and some aspects of the guidance on screen at the moment will probably therefore need to change. So we probably wouldn't expect people to record positive result for PCR antigen test, for example, but use one of these new codes we released yesterday to say positive result of test for the organism. I'm not telling you how it was done, I'm just telling you it was positive. So there are likely to be changes to this guidance over the next 4 or 5 weeks, I would imagine, to align with what came out yesterday.
Thanks, Jeremy. Can I just clarify, just from a purely Scottish perspective, we're not using SNOMED, so I think I'm just probably asking that question from a non-SNOMED user. Are these other codes going to be required as local, to have local equivalents? And if yes, is there a mechanism for doing that?
So
Do you do
could
it?
could I come in on that? First of all, to confirm what Jeremy says, the faculty has 2 representatives on the Pathology Standards Governance Board, where all of this stuff is being discussed in detail. And I think the clinicians on that board want to make sure that any solution that we have will work everywhere in the system and across the 4 countries as well, not just the GPs in England, in other words.
Yeah.
The positive, negative, equivocal unknowns in England will be, for English systems, will need to have pre-coordinated SNOMED CT concepts. So you'll have something that says the test is positive, the test is negative, the test is equivocal, the test result unknown. So if they are specific SNOMED CT concepts, we would expect that the suppliers in England will again have to produce the matching system-wide local codes. And if we can get our guidance act together again, we can go to the suppliers and say, we want to ensure that you do this for all of these things, because yet again, we will want all of these to be usable across the entire UK, if not as SNOMED in England, as these system-wide local codes in exactly the same way as the 19 we've been talking about here.
Great, thank you very much.
Thanks, John. Can I now ask Emma Davis to put the question that she wanted to put?
Hi, we've been going through sort of the GP data, trying to cross-match the criteria which were meant to flag up the COVID high-risk patients. And the criteria is obviously quite vague in places. Some things are very clear. If they have leukemia, it's quite easy to flag a patient up. But if they have had heart disease, which type of heart disease do they mean? Is there any read codes? Is there a read code set that we can do a cross match on, so we can actually go through our data sets and try and see if we are catching all those patients, especially if we can start cross matching it with hospital data, which is something I wouldn't mind if we can work out how to do. That would be really quite handy. But I don't know if that data set exists.
I can try and pick this up. My name's Ian. I'm involved with the shielding work in Scotland. I'm aware that some of the suppliers have developed audits based upon the national extract that was done. I have concerns that the extract that was done is wider than what the defined shielding set is. Whilst the shielding definition in the way it's published is a little bit vague, there are actually very explicit definitions on NHS Digital's and Health Protection Scotland and the National Wales Informatics Service that give very explicit lists of the codes that have been done, and it's actually quite complicated. I am awaiting a response from NHS Digital as to whether they have asked the GPIT suppliers to produce searches or audits, depending on what you call them in your system, that would help GPs to facilitate identifying people who they think should be on the shielded list. In Scotland, we've used a separate system that is supplier agnostic to help us identify the gap in prescribing data between centrally identified people where we have data up to the end of December and people who may have had prescriptions since then, where that would put them into the shielding cohort. But it's a question that really probably needs to be asked of NHS Digital in England, and I'm not sure that there's anybody on the webinar that would be able to pick that up.
So it's Jeremy here. I've been peripherally involved with the shielding and vulnerable patient lists. So I can give an answer which is based on my understanding of how it worked and some of the reasons why it is the way it is, but would caveat that by saying this is not the official position that the team might give who are doing this. And just to clarify, if I use the word shielding list to mean those in the highest category risk, those who need to hide away for 3 months and have food parcels, and vulnerable list to mean those in the elevated category of they should be very cautious, but we're not going to give them food parcels. but we need to know who they are. And then the low risk is everybody else, basically. So the priority early in, I think, February time for the shielded patient list decided, for better or worse, to compute the membership of that list using HES data, which is ICD-10 coded, possibly some OPCS coding in there. I'm not sure. I think they only use the ICD element. Extracts of the maternity data set that tell them who is pregnant, and a extract from the BSA, Prescription Pricing Authority, of the last 6 months of prescription issues not being cashed in. I think I forget, it's not quite what was picked up. It's the list of, anyhow, yes, so primary care and secondary care prescribing patterns, or something that's a close proxy for that. And they devised a set of largely ICD-10 codes that would be used in combination with the prescribing codes and whether somebody's pregnant or not, according to the maternity data set, to build the shielded patient list. And that's why there is no read coding or SNOMED coding that you could run locally to duplicate that list. There are a number of interesting characteristics in it, for example. So the ICD code cluster includes the code for asthma. Now, you wouldn't want all asthmatics in a primary care setting to be counted as needing shielding. But of course, you only get the ICD-10 code for asthma in your HES record if it was bad enough to warrant hospital admission. So the ICD code for unadorned asthma in the context of a hospital admission is quite a good proxy for severe asthma. In primary care settings, it's much harder to come up with a single code that will tell you who is a severe asthmatic. Clinicians, although I think there is a code, John will correct me, or one of the Johns will correct me, there may be read codes for the asthma is severe, but by and large, the majority of asthmatics in this country in primary care are just coded with the catch-all code for asthma, and the severity of their asthma is sort of represented by other aspects of their prescribing record and their peak flows and spirometry results and all the rest of it, but it's not explicitly recorded as a single coded item. Their asthma is grade 5 or grade or severe or whatever. Similarly, at the centre, they use the maternity data set to work out who is pregnant. And of course, notoriously, if you ask a GP system who's pregnant, they're not that accurate. And so there are aspects of the definition of the vulnerable and shielded patient list which are in fact very difficult to duplicate if all you look at is primary care records. In the same way, there are aspects which are quite difficult to get accurately correct at the centre. So there are at least some patients we know of who caused some surprise at the local general practice when they were turned up as being on the shielded patient list. And digging deep enough, the explanation was that they had been admitted to hospital for something else, maybe just as part of a routine maternity episode, and had been given the ICD-10 code for sickle cell anemia, when in fact they only had sickle cell trait. So they're miscoded in the HES data as having sickle cell disease and therefore legitimately on the shielded patient list, but because of a miscode in the HES data fundamentally, which, because it's primarily used for payment systems rather than clinical decision making, can tolerate that kind of miscode. So it's a grand informatics problem. In terms of your other sort of follow-on question about extract of GP data, yes, I do believe there is a specification, a modified specification of the GPES extract, which is in publication now, going out to the suppliers, which aims to recover slightly more targeted data than the normal GPES extract in order to support a rehash, I think, of the shielded patient list, but also probably more likely an attempt to compute the vulnerable patient list, and bringing in again the maternity data set and other information for the same reason, to try to make it more accurate as a centrally determined list. I think there has also been some development of clarification about how GPs and in fact patients can correct the list or self-identify. Ultimately, the list needs to be collated centrally if you're going to pass it via the Cabinet Office to Sainsbury's, so they know who to deliver parcels to. The logistics of all this is turning out to be quite an interesting informatics challenge, and we are where we are at the moment.
Thanks, Jeremy. That it was a surprisingly comprehensive on. Thank you very much.
May all be false, but that's my best understanding.
Thank you. That's really helpful.
As a possible supplementary, whether Di Evans would like to comment about the templates which have been produced by EMIS and TPP and Vision that he knows about. If Di's
yeah, I'm here. I'm still conscious. Sorry, it's been a tiring time. Yeah, so I guess my take on this is I've been part of a long-running kind of quasi-mothballed pandemic preparedness project, which was funded after the swine flu epidemic in 2009. We kind of had it in a mothballed state. And the idea was that come a pandemic, we would deploy a triage template across the 4 clinical systems to partly collect data, but partly also to help GPs assess who is at higher risk of a bad outcome and who you can safely triage to stay at home. Luckily, I think for most of us, we may escape this role as having to triage in this way, but it is actually happening in hot clinics and certain circumstances, residential homes in particular. So as part of this project, it's an NIHR, so National Institute Health Research project, and that was activated sometime in February. And as such, we had a core template that was pretty closely based on the News 2 objective assessment that we firstly had to convert into SNOMED, and secondly, then take on board what we knew about COVID and then stick that or align it with the national COVID workflow. So many of you on the call will have seen this kind of infogram of a care pathway for patients through care. So from our aspect, it was about getting aligning the data capture we had with the real world, and then implementing that across the 4 system suppliers. So EMIS's template was launched last week and is under a weekly review, and it's across the 4 nations. So both in web and PCS, to answer Ian's earlier question. TPP's is on a pull version at the moment, so it is there and practices can pull it down. Vision, I was in communication with this morning, so they're aiming to start development. Microtest I haven't heard of for a couple of weeks. The other catchy bit about this is there's an associated data extraction. So what we're doing is on a weekly basis, pulling data back to look at the data captured in the template alongside patient comorbidities, alongside patient outcome, be it death or hospital admission. And the idea is then that we can send this to a WHO team and they will analyze those data sets and try and characterize certain aspects as to whether they are high risk for patients of a poor outcome, or you can safely send the patient home. And we would then fit that back into the templates. So that's a kind of brief summary, I think, of where we're at.
Great. Well, that's really really interesting to hear from you, Di. It's now 1:30, and it's time for us to close this interesting webinar. Just by way of summary, we're going to keep the coding sheets on the FCI website updated, and we will be publishing this in an edited version on the Faculty of Clinical Informatics website. We've also got a series of other webinars planned in the near future, and I would recommend you have a look at the COVID resource panel on the FCI website for that. So thank you very much for everybody for attending. Thank you to the panel for their hard work over the last few weeks preparing the list and this webinar. With the caveat that if anybody else wants to say something before we close, I think it's time to finish.